Welcome to Modern Management of the Older Adult, brought to you by the Institute of Clinical Excellence.
Hello everyone, my name is Kay Mayerdomo, and if you don't know me yet, I am part of the MMOA crew by the Institute of Clinical Excellence. Before we get right into our topic for today, I just wanted to remind you of a few of our courses. So MMOA Essential Foundations is starting again March 1st. Advanced Concepts will begin May 4th. So it's never too early to start planning, especially if you're finishing up Essential Foundations and want to go straight into Advanced Concepts. And some of our live courses are that are coming up February 11th to 12th. There will be one in Sparks, Glencoe, Maryland, February 18 to 19 in Kewanee, Illinois, and March 4th to 5th in Brookfield, Wisconsin. So perfect. So we'll go straight into the topic for today. So risk versus reward, HIIT training in older adults with comorbidities. So when we're working with our older adults, it can be really easy to dismiss higher intensity work as they have comorbidities. We should be careful. We should be mindful of these comorbidities. But what does that really mean? And what guidance should we be giving other clinicians who are curious about HIIT training in older adults with comorbidities? So today, that is exactly what we are going to go over. So the risks. When we work with our patients, I know that we want to do our best to reduce the risk of adverse events. So Rogmo et al. Examined the risk of cardiovascular events during HIIT, so high intensity interval training, and moderate intensity continuous training among 4,846 cardiac rehab patients with cardiovascular disease around the age of 58. These authors reported just one fatal cardiac arrest during moderate intensity continuous training and 2 non-fatal cardiac arrests during HIIT training. And then they also found that the rate of complications to number of hours of training was 1 per 129,456 hours of moderate intensity continuous training and 1 per 23,182 hours of HIIT training. Of course, in the study that they did a pre-exercise evaluation, they definitely recognized the relative and absolute indications for avoiding and terminating exercises, as well as taking into account special considerations for older cardiovascular disease patients who may present with various comorbidities attributing to aging, like frailty, sarcopenia, balance, cognitive decline. So from that research, we can see that the chances of something like a cardiac arrest is relatively low, even with patients who are undergoing cardiac rehab. And although the risk of not implementing is pretty much, well, we just don't see improvements in blood pressure. We don't see improvements in respiratory health. We don't see improvements in resting heart rate. So the patient either stays the same with their comorbidities, or it could even continue to get worse. And as healthcare providers who promote health, and we are technically considered movement experts, shouldn't we be at the forefront of figuring out how we can improve these patients' health outcomes? Not just reduce pain, because if we don't, who will? If these patients continue to be deconditioned, what if they end up, let's say, like going to the snow and doing some high intensity work, shoveling snow or exerting more effort than usual, like post holing in the snow or something, or their grandkid decides to run away from them, or their dog sees a squirrel and they have to run after their dog who gets off leash. What if their body hasn't been trained to do those high intensity things anymore? Whose job was it to help them get there? So I just want you guys to really consider the risks of not doing HIIT training or some kind of higher intensity training for our patients who have comorbidities, because they are really the ones that could benefit the most. So now we're going to talk about reward, which we kind of talked about above too, but in the same article I mentioned above, in older adults with cardio or coronary artery disease, they definitely showed an improvement in peak VO2, a decrease in resting heart rate, and systolic blood pressure as well. And in older adults with heart failure, they also saw an improvement in VO2 and an improvement in left ventricular diastolic dysfunction. If you're still not convinced, there's another study by Blackwell et al. In 2021 that took men and women with comorbidities and had them go through HIIT sessions lasting 16.5 minutes 3 times a week for a total of 12 sessions, so total of 4 weeks. They used a cycle ergometer of a 2-minute warm-up and then 5 1-minute exertions at 100 to 115 of their max load in watts in between 90 seconds of unloading cycles and ending with a 2-minute recovery period. They saw that the HIIT had an improvement in cardiorespiratory fitness and fat-free mass, and their conclusion was that HIIT can be delivered to octogenarians, pretty much patients in their 80s, with comorbidities, and is effective and time efficient in a short period of time. If you're worried about your older adult patients who have very low exercise capacity, you can always start with shorter bouts of high intensity sandwiched in between lower intensities to start to ramp up their capacity. We have to remember these changes don't happen overnight, but they do happen. And when we talk to our patients about doing HIIT, we want to make sure we're really giving them what to expect. They should know what to expect. That it should feel hard in however many seconds you give them, but they'll have periods in between of less intensity. So pretty much what I'm trying to get at is, of course, we need to be mindful of yellow and red flags to exercise, making sure to monitor whether your patient is having an appropriate response to exercise, and gathering their RPE, which in the Blackwell study, they had patients working at an RPE below 8 out of 10 to monitor the intensity. And the thing with RPE that it varies between everyone. Like, you could be working at an RPE of 8 out of 10 and really sprinting out a really high wattage, and your patient could also be at a similar RPE but be at a much lower wattage, or even vice versa. So RPE is a really great way to gauge intensity, and if you just don't feel comfortable starting your patient with a high RPE, you could have them go through something like a more moderate intensity continuous training. But also that still didn't show as much improvement as the HIIT groups. So if you're a physical therapist who isn't necessarily familiar with HIIT training, I would really encourage you to try it out. You can try something like a 10-second sprint with 20 seconds of a slower pace, or like the Blackwell study. I'm just going to repeat it so you guys could try it out if you want to, but you could do their HIIT session lasting 16.5 minutes 3 times a week. They did 2-minute warm-up on a cycle ergometer, 5 1-minute exertions at 100 to 115% of maximal load in watts, in between 90 seconds of unloading cycles and ending with a 2-minute recovery period. So at MMOA, we say this a lot, but if you want to be comfortable pushing your older adult patients, you have to have some idea of how it feels. So in the last couple of minutes, you've heard it for yourself. There's a significant difference in improvement in patients with cardiac issues and comorbidities when they go through HIIT training. I just don't think we should sleep on it. If the data is really showing that HIIT can improve things like VO2, blood pressure, resting heart rate, which could in turn increase a patient's ability to continue to perform exercises and reduce comorbidities that can contribute to poor health, what are we waiting for? We don't want to do a disservice to our patients who are appropriate for this type of intervention. That's all I have for you. So if you are interested in reading the articles I mentioned more fully, I'll link them below in the comments. Have a great day, everyone.
Thank you for listening to the MMOA podcast. If you found this helpful, please share with someone that could benefit. And if you're looking for more practical content to help you better serve older adults, head over to www.mmoa.online, where you can learn more about our free resources, our community, continuing education courses, and our certification. Once again, that's www.mmoa.online. Thanks for listening.